Thank you all again for joining. My name is Siobhan Robinson Marshall, and I am a research assistant at the Center. And on behalf of everyone at the Center for Global Health Security and Science and the Global Health Initiative, I'm pleased to welcome you all to our first Global Health Security Seminar Series. While this is our first virtual offering, the series began in September 2017 in a joint effort to promote a greater dialogue surrounding health security across Georgetown University and the wider Washington, D.C. community. Since its inception, the Center and GHI co-sponsor these seminars monthly throughout the academic year. And while it's unfortunate that we cannot meet in person at this time, we are very excited that we are able to expand our reach with a virtual seminar. So thank you again for joining us. And I will now hand things off to Dr. Alex Phelan, who will introduce our speaker.
Thank you so much, Siobhan, and welcome everyone. I can't think of a better way to start our fall 2020 seminar series than with Dr. Clare Wenham, who we're incredibly fortunate to have from the London School of Economics and Political Science, where Dr. Wenham is an assistant professor of global health policy. She specialises in global health security and politics and policy of pandemic preparedness and outbreak response through analyses of influenza, Ebola, Zika, and of course the current COVID-19 pandemic. Dr. Wenham's work examines global health governance, the role of international institutions like the WHO, national priorities, and innovative financing for pandemic control. And most recently has been examining the downstream effects of global health security policy on women with a forthcoming, it's out now, an OUP book offering a feminist critique of the Zika outbreak in Latin America and a number of efforts in regards to gender and the COVID-19 response. Her work features in leading journals, including The Lancet, BMJ, International Affairs, Third World Quarterly. And she's just published an excellent piece that I highly recommend as a sort of supplement to today's topic on COVID and international relations with Dr. Sarah Davies in International Affairs, which we can pop the link up on the page. So Dr. Wenham, thank you so much for joining us and very much looking forward to this morning's presentation.
Thanks, Alex and Siobhan and everybody for joining today. I'm really honoured to have been asked to present to you today and present some of my work around the impact of outbreaks on women. And particularly if it's your first series, I think starting out talking about women is a good place to start, so they're not just an afterthought. So I'm really honoured and thank you very much for the kind invitation. So I'm going to share my screen because I've got some slides. Don't worry, it's not going to be death by PowerPoint, they're mainly pictures. So the question I want to pose to you today in this seminar is to basically ask, where are the women? How do we think about women in this coronavirus outbreak? And I've been working on this for a few years, and particularly, well, not obviously in coronavirus, but in other outbreaks. And particularly when it comes to COVID, and I start talking to people and saying, oh, I'm working on work around gender and COVID and women and COVID. The immediate response I get is, well, why are we worried about women? More men are dying. Right? More men are getting it, more men are dying. Why are the feminists getting up on their high horses and asking about women? Because this is a men's issue. And they're right to a certain extent, right? We see this is the latest data we have from of sex disaggregated data of cases globally, which is from July. And the astute amongst you can see that this is not the summary of the cases that were present in July. One of the problems we have when we look at gender and COVID is the lack of data. Right, so currently only about 44% of global cases are disaggregated when they're reported to the World Health Organization. So honestly, we don't really know if it's true that men are, being infected more at the global level. If we think about all cases globally, this is just based on the 44%. So I think that starts off by telling you something quite important around what's important when we talk about women. Why are we not trying to understand the difference between men and women and how they are being infected with this outbreak? Because if you think about it, I mean, every time you enter any health clinic anywhere in the world, one of the first bits of data that will be recorded about you is, M or F. And so, why isn't that then being carried out? But we do know from the data we do have that, men are more likely to suffer the worst health outcomes of the coronavirus outbreak, right? So we know that you're more likely to be hospitalized, you're more likely to be in ICU, you're more likely to die if you are a man than a woman. However, what I try and show in my work is that it's not just being infected, it's about the affects as well, more broadly. And thinking about it in very clinical terms misses this big, broader nuance of how men and women experience and or are vulnerable to outbreaks differently. And I always come back to this starting point, which is that if we want to understand health security for all people anywhere on the planet, we need to understand the embodied reality of people's lives, right? That why some people have health security and some people don't. And this means we need to actually look at the discourse of global health security, which renders invisible actual people and just talks about case numbers, for example, rather than talking about people and their lives. And it illuminates how actually a lot of the structures of governance that shape global health security impact on people's chances, right? So this doesn't necessarily have to be about gender. It could be around, race or ethnicity or location, but to recognize that these are not, people don't experience outbreaks in the same way. So then that got me thinking, well, let's look at these structures of governance, right? Let's look at these structures of governance in global health security and see how they think about gender or about women. Well, I don't know how much experience that you all have in different structures of global health security. I'm guessing as a global health security seminar series, a lot. But if you look at some of the key structures of governing outbreaks, the international health regulations, the joint external evaluation, the global health security agenda, the biological weapon convention, the national security strategies in the UK, the US, none of them mention women. None of them mention gendered impacts of outbreaks, right? So it's not even on the mindset of the policymakers who are then implementing these policies or developing these policies, right? When we do see mention of gender, for example, in the IHR, it's simply about representation on panels, right? It's about high-level executive representation in an IHR review committee. It's not about, well, actually, what are the effects of implementing this policy? We saw no mention of gender in the reviews of Ebola, right? And in the Harvard LSHM panel, in the Stocking report, we haven't been having this conversation, I would argue, until now about gender and how outbreaks are impacting women differently. And this is not to say that we need to think about women and gender and not think about the epidemiological. It's not to diminish the importance and the vital importance of epidemiological and clinical information and data when we make policy and we try and respond to outbreaks. But actually, it's about producing a different analysis as well. It's about recognizing the downstream effects of policy, which is just focused on disease transmission and interventions to stop disease transmission, have these ripple effects, right? And that actually, by doing so, and by recognizing these ripple effects, you can then begin to look at the narrowness of the global health security agenda, right? Or the global health security regime, however you want to define it. And this focus on sort of prevent, detect, respond is so neutral in its approach, but this neutrality fails to recognize the unequal burden of infectious diseases on women. And so now what we're seeing is this really difficult understanding of women in outbreaks, because on one hand, they're being completely ignored and we're not recognizing them and what I'll come on to talk about today, all the ways in which women are burdened by outbreaks. But at the same time, women are, lauded as heroes. We're going out to clap the carers who are all women. And it really makes you think about, well, why are we not embracing this presence of gender? And so what I want to argue today is that actually, we need to think about how are we going to put women back in the global health security picture? How are we going to ensure that we're going to see different policies which are more gender sensitive? And so what I wanted to talk about was to think about ways in which outbreaks are gendered and ways in which women are disproportionately impacted by outbreaks. So the first way you can think about this is through the heavily feminized sectors of the economy, which are related and dependent on outbreaks. So the obvious one is healthcare workers, right? We know that 70% of the global healthcare workforce are women, right? So not acknowledging this and not acknowledging the role that women have played, so when we talk about essential workers and frontline healthcare workers, is women. right? Not acknowledging all that formal care that women are doing into the economy, into caring for people, into understand, not acknowledging that this is women and women's labour and women's time and women's mental health issues and all the other impacts. It is missing something here, right? It's not simply that it's an equal split there. And it's not just around health as well. So this slide shows you a graph along the x-axis is the share of or percentage of female sectors. So how many women do you have in each sector? And the y-axis is those who are most exposed to being infected with COVID because of the close proximity of your contacts in your daily job. And so what you see here is actually, there is this interaction between jobs which are highly feminized and those which expose you to risk of being infected. And it's not just the healthcare workers that are circled here in the top. It's also, if you go one step down, it's also education, right? And personal services and people who work in supermarkets and people who work in restaurants. These are all heavily feminized sectors of the economy, and therefore women are disproportionately exposed to potential risk. And we can see this in the data around which healthcare workers, for example, are being infected, right? The 70% of healthcare workers who are infected with coronavirus are women, right? And that is simply because 70% of healthcare workers are women. So it's not that surprising. But when we talk about healthcare worker infections, we've got to recognize that these are women. And it's not just about these feminized sectors are not just putting people at risk of infection, but these feminized sectors are also putting people at risk of losing their jobs, effectively. Because the industries which have been most affected by lockdown, by staying at home orders, by not being able to go out back into society, are those which are heavily feminized, right? Accommodation and food services, education, wholesale and retail trade, right? These are things that shut down for a while. And that means women were shut down for a while and they weren't able to work. These aren't jobs that you can do at home. So a lot of women weren't able to work. And then it's not a massive leap of faith to see that, well, that led to greater female unemployment. And this is just from the US Bureau of Labor Statistics, but this is a trend we see all around the world. Basically, more women lost their jobs in the early part of 2020, and those who, like in the UK, that have furlough schemes, more women were furloughed than men because of the nature of their jobs and the industries they were working in, which were shut down. But it's not just at the macro level, like which sectors of the economy were shut down and which sectors of the economy employ women. There's also micro level effects too, right? So we also know that the reason that more women might have lost their jobs, and the reason that more women might have chosen to leave their jobs or might have chosen to seek furlough if you're in a country which offers social protection schemes like that, is because of the domestic burden and the unpaid care, the informal labour that women perform at home, which suddenly multiplied. You close schools, you close workplaces, everyone's at home. Who's looking after the kids? Who's doing the washing? Who's doing the cooking? All of this stuff that actually, if you look at political economy, international political economy, it is well talked about, right? We talk about social reproduction, which is everything that happens in a household which allows the man to go to work effectively, right? And it's heavily gendered. And this is both, and so suddenly, schools closed, everyone's at home, people are doing homeschooling, people are looking after their kids. And that has become heavily gendered as well. It's predominantly women doing this, right? And partly that is gendered norms and kind of societal norms that women tend to look after their kids. But it's not just norms, it's also related from sort of labour force patterns, which is the sort of gender pay gap, right? Which is that actually if you're in a dual household, a dual parent household, and one of you is going to continue working, in the living room, and one of you is going to look after the kids, you're going to put the person who continues to work, who earns the most, continue working, right? And we know that men consistently earn more than women, and in fact today is the day that women in the world should stop working, because all work women on average work that women do after today is basically unpaid compared to men on an average annual income basis. So actually, it's both kind of macro decision making and the effects of the labour force, which means that women are leaving employment to look after kids during the outbreak. And I include a picture of me trying to do some homeschooling with my daughter as well. And we can see that this comes out quite substantially in the data. So this is UK data, but we can see that during the the early months of the outbreak at least, we can see that women were doing more unpaid work during lockdown and their paid work went down, and men were doing more paid work and doing less of the unpaid work. And so this comes out quite starkly, right? Men are still carrying on their jobs, women are picking up all the additional unpaid work. It's unfair to say that men weren't doing anything. We do see that men have increased their contribution to informal care, unpaid labour in the household compared to baseline before the outbreak, probably because they're just at home more, so they can contribute more. But I think the really interesting thing in the UK was we looked at the difference, or the ONS, I say we, the ONS looked at the difference between what jobs men and women were doing in the house. And actually, we can see that basically men were doing more developmental care. So that's the homeschooling, the playing, the kind of, having fun with your kids part. And women were doing more of the non-developmental care, which is the, are they fed? Are they clean? Have they got clothes? All the stuff that you need to look after a child and keep them alive and happy, rather than all the stuff which is, the fun part. So that also tells you something about who's doing what in the home and what domestic roles people are performing during the outbreak. And then let's look at Panama, right? Because if you want to see what's going on during the outbreak, let's look at Panama. So I don't know if you guys know what Panama implemented during the lockdown, or at least in the early stages. I know that actually they've just re-implemented it. So in April, Panama decided that they were going to reduce the risk of disease transmission through locking everyone down in a quarantine, and people are allowed to go out to the pharmacy and the shops. But men and women could only go out on alternate days. So women were allowed to go to the shops and the pharmacy on Monday, Wednesday, Friday, and men were allowed to go out Tuesday, Thursday, Saturday. So we did some analysis of this looking at Google mobility data, and we obviously saw this quite interesting trend, right? Which is suddenly two days a week, 2 spikes a week, people are going to the shops more. And I looked at it and thought, interesting, right? Women are doing it. Women are going out to the shops more than men. Surprise, surprise. Is this a really surprise to anyone? But then we looked at it a bit closer, and it's men's days. It's men's days. Men were going out to the supermarket more than women, quite considerably and significantly. And this goes back to this developmental and non-developmental childcare. If you're in a place of lockdown where the only thing you can do to get out of your house is go to the supermarket, that represents a different household bargaining to where you were before, right? That becomes the thing that everyone wants to do because it gets you out of the four walls and gives you a breather from your family. And so men are doing it. And I think that tells you quite a lot around the gender dimensions, which are, universal. We see it in the UK between who's doing what childcare and then who's doing what domestically in Panama during lockdown is also quite interesting. And this has significant effects. So we did some polling in the UK around how people were enduring the lockdown. And surprise, surprise, everyone is unhappy or less satisfied with their life because of lockdown. Well, I don't think anyone on this call would disagree with that. But we see that women are less satisfied with life now than men. Right, and we're also seeing increasing rates of anxiety and mental health concerns amongst women more than men. And actually, it's not just women. Women are not, a catch-all term, but the people who are the most anxious are mothers with young children. And you can see quite stark differences between the anxiety and mental health concerns about mothers with young children compared to people in their same age category who do not have children. So I think that's telling us something important. And so why are we thinking about this difference and this division between paid work, unpaid work, why it matters in outbreaks? Well, because this has long-term effects. So this is not new, right? The fact that the outbreaks affect women's economic participation is not new. During Ebola quarantine measures in Sierra Leone and Liberia closed markets, right? And market traders, market workers in these countries are predominantly women. So a lot of women lost their jobs. So, we're seeing this on a macro scale at the global level, but it's the same reason. What's concerning is that in the Ebola outbreak, 13 months after the first case was detected, 63% of men have returned to work compared to only 17% of women. So these economic impacts around women's participation in the labour market and in work have long-term effects, right? And we're still trying to understand why in Ebola, but the thought is that basically either women weren't able to access capital to reset up their stalls, or they were still doing more childcare because schools weren't open, right? And so they were still able to look after their kids. And so I think that can lead to a really clear question now for policymakers, which is, what are we doing now to make sure this doesn't happen in the long term? How can we ensure that as the economies reopen, and I know that we're going through these cyclical lockdowns again, and well, certainly here in the UK, how can we ensure that we're not limiting women's participation to be able to go back to work, right? And one of those key things is, how can we ensure that childcare is open? So here in the UK, we started opening, or the government started opening up sectors of the economy, construction, manufacturing, pubs, bars, restaurants, but didn't open up childcare providers. And so if women are performing that work, they're not going to be able to then go into their paid employment. So that's a really easy thing that governments can focus on. Just focus on getting those building blocks out to facilitate women's participation. And there's loads of studies which show that having women back in the economy leads to more economic profit in the long run. So it's a kind of win-win round. Moving away from economics, though, outbreaks also affect and distort health systems, which we widely know and have seen. But for women, they also disrupt maternal and sexual reproductive health services. So we know that when outbreaks happen, we see, and as we've seen with COVID, what happens is anything that's deemed non-essential doesn't happen. And in a lot of places in the world, maternity care, antenatal care, and SRH services are deemed non-essential. So we saw that in Sierra Leone, where during Ebola, all provision of antenatal care stopped to divert resources to Ebola, and that meant that the same amount of women died of obstetric complications and maternal death than people died of Ebola in the same time span, right? So it raises really difficult questions around whose lives matters, right? And why are we focused on Ebola at the cost of women dying in childbirth, effectively? We also saw increased rates of teen pregnancy in Liberia, and just an inability to be able to access services. And that's what we're seeing again here, right? We've seen widespread supply chain disruption for contraceptives as a consequence of the travel bans, changes, reductions for COVID. We're also seeing a change on the demand side for using these services. So some women just say, look, if I've got to go to a clinic to access these services, I don't want to go, because I'm worried that that's a point of transmission, and I'd rather stay here in lockdown. And then at the kind of, the big question, or the big hot question, I guess, is around how outbreaks can actually affect whether you can access an abortion as well. And you're seeing some quite different policy responses to this. So in the UK, in England, I shouldn't say the UK, in England, at the beginning of lockdown, the government changed our legislation to be allowed to have a medical abortion, a self-managed abortion at home. And you could just go to a pharmacy and pick up the pills, and you didn't need to take those pills in a clinic, which is what you needed previously. So that this would limit strain on the NHS and mean that women would feel safe to take them at home. The opposite happens in some of the states in the US, where actually abortion is deemed non-essential, so it completely stopped, right? And it was another way that this abortion debate played out with the crisis of the pandemic. And this has real-world effects, right? So if we just look at Marie Stopes International, which is a big provider of sexual reproductive health services, they think that just through the changes to their programs, the COVID outbreak is going to lead to an additional 1.5 million unsafe abortions, 900,000 unintended pregnancies, and 3,000 additional maternal deaths. And this is happening already. There was a piece that came out in the Lancet Global Health last month, which is showing that in Nepal this is already happening. There's increased rates of maternal mortality, there's increased rates of stillbirth, and so this, we need to think about this now, and not so we don't put more women and children's lives at risk. We see issues of the gendered effects around domestic violence, right? And again, what happens when you lock everyone down in a house? Well, domestic violence is going to go up. We know that most domestic violence happens in the home. So if you lock everyone up, everyone's stressed because they've lost their jobs, their kids are at home screaming. It doesn't take a rocket scientist to see this. and it happened in Zika, and it happened in Ebola. So it's well evidenced, right? And just to put this in perspective, in the month of June in El Salvador, there were the same amount of cases of femicide than there were of deaths of coronavirus, right? So this is a really serious problem. And the fact that governments weren't thinking about it, or it didn't even cross their mind till after a lot of this happened is quite alarming when all the signs were there. But as I mentioned before, not all women are the same, right? So women interact differently and will experience outbreaks differently. And using this analysis and thinking about the ways that outbreaks affect different communities doesn't just tell you about how women experience outbreaks compared to men, but you can use the same type of analysis to understand why we're seeing these differences in race and religion and ethnicity and location. And that actually, you know, we need to move beyond this kind of simply using a case number and think about who those case numbers are. Because without doing that, you're then seeing these trends, right? You're seeing these trends, you know, everywhere in the world. This is just from the US, which is that you're much more likely to die if you are not white Caucasian of coronavirus, right? And it's not just about being infected and those effects, this structural racism that we see across societies and across health systems, but that the decisions change. So, you know, if you're poor, you're going to make a very different decision around lockdown to if you're not, right? If you're like, well, actually, I've got to go to work, so I don't go to work, I'm not going to earn any money to feed my kids, then actually your decision-making process is very different to how you're going to experience COVID, how you're going to understand lockdown. And so it's not just thinking, you know, doing this sort of gender analysis isn't just thinking about women, it's thinking more broadly around, you know, different groups, different vulnerable groups, and how we can recognize that people aren't all the same. So when I talk about gender and women in outbreaks, in COVID, a lot of people have picked up recently on the role of women's leadership. And if you look at the countries around the world where they're managing the crisis well, there's been this weird understanding of maybe it's because they've got women leaders, right? New Zealand, Taiwan, Germany, Scandinavian countries. They've all got women leaders. And is there something in women's leadership and women's leadership style and prioritization which means that you're going to handle an outbreak? I'm not sure I agree with that argument, mainly because I think the sample size is too small, and I think there's only 14 world leaders who are women, so how can we possibly make assumptions based on that as a whole, around women as a whole? But I think there's a nuance there. I don't think it's women that are doing, I mean, these women are doing fantastically, let's not negate that, but it might not be because they're women. It might be because men are doing badly, and not just men are doing badly, but a particular type of man and a particular type of kind of alpha male populist leader. And I've got Trump here to be provocative, but it's Trump, it's Bolsonaro, it's Boris Johnson. They all have this very different, this almost similar populist, macho, alpha approach to it. And it might be that that's a particularly bad style of leadership to respond to outbreaks, as opposed to women's leadership being exceptionally good. I don't think we know the answer yet, but I don't think it's quite as simple as women's leadership. And so to kind of bring this back to think about what can we learn from this, right? And what can we learn about why this is happening? Well, partly it's because of the urgency. When outbreaks happen, it's about all hands on deck. How can we stop this? How can we end the outbreak? And so these broader structural issues around the socioeconomic effects and the determinants of why some people experience outbreaks differently can get overlooked, right? But I would argue that's not an accident, right? And that the way that you construct health security, the way that health security policy is written without the inclusion of women and without the inclusion of gendered considerations leads to them being ignored at the time of crisis. And actually, if you had included those safeguards within policy, that might lead to better effects, or rather better recognitions of the potential effects of women in outbreaks. Because there is this stream of argument which basically says that the structures of global health governance are masculine, right? And that any policy which is presented without any reference to gender has this implicit masculinization, right? And that even if you think about what's considered to be important and what's given this epistemological authority in policy making for health is all about epidemiology, clinical data, and it doesn't think about other ways of collecting data. It doesn't move kind of, without getting too sort of into the kind of social construction of it, but it doesn't move beyond the kind of quant to think about the more qualitative research, to sort of feminist methodologies that could go into this to recognize the individual experience. But if you go back to the international relations literature on security and securitization and how issues become security issues, Lena Hansen says that if security is a speech act, so by saying something's a security threat, we then turn it into a security threat, then it's also simultaneously deeply implicated in the production of silence. So if we don't talk about women in our security policies, then they're going to be absent of considerations of women in them. So this is really me pushing to say, let's get more discussion around gender and women in health security policies so that this doesn't happen again. And this is, not new. This is not new in international relations. This is coming from feminist security studies, which is a whole subdiscipline of international relations, which looks at how do you move beyond concepts of war being masculine, war being about states and state power, and understand what's missing from that, right? And it's not limited to women, but it's more, well, what's the effect of these wars between states, and thinking about security in a very national security term, what gets missed. And then the next step is, well, what would this look like if we did put women in it, right? What would policy look like? What would national security policy look like if we did put women at the center? And what would a global health security policy look like if we put women at the center of it? Well, I think it might, firstly, it would recognize that you need to recognize all these gendered effects, some of which I've mentioned today, right? And ensure that these gendered effects are mainstreamed into policy when it's made, to understand that if you're talking about stopping disease transmission and you're worried about the epi, there are all these ripple effects that happen after. And that's not going to happen without someone who knows about it, right? And someone who would even ask those questions. And a lot of the conversation at the moment is around getting more women into decision-making powers. Now, I completely support that, 100% support that. But being a woman doesn't mean you understand gender. Being a woman doesn't mean you understand the variety of effects that might happen on women caused by outbreaks or lockdown or whatever it might be. You need to have gender advisors. You need to put people who specialize in this, who can preempt what these issues are going to be as policy is written. We need to push governments and the WHO to report all their data, sex disaggregated, to make sure we actually know what's going on. We need to ensure that those who are on the, if a policy which was gender mainstreamed and was putting women at the center would also focus on frontline healthcare workers, right? Women who are doing the work, and make sure that if we're calling them essential workers in this crisis and we're saying they're the only ones who are still going to work, then let's make sure that they're paid and they're recognized in their economic decision making, right? If this is what governments realize is what you need to maintain society, then let's, recognize that with how they are treated. Putting women at the center of global health security policy would also think around, well, what happens when we open sectors up? Which sectors of the economy are going to get bailed out? Is it going to be the sectors we usually see being bailed out in recessions, those of financial services or construction or manufacturing? Or are we going to think about bailing out those sectors of the economy that I talked about at the beginning, which are heavily feminized and where women are losing their jobs, your childcare, your education? How are we going to recognize all the unpaid care work that goes in to life, right? And recognize that that's heavily gendered. How can we ensure that not only that's recognized by policymakers, but when decisions are being made around going back to work, particularly if schools aren't open or you don't want to send your child back to school, how do we make that decision not based purely on a gender pay gap differential, but make it based on who, a more equal footing, right? Are there stimuluses we can give to families to reduce that decision making based purely on finances? Can we ensure that you can access SRH services in your pharmacy or in your supermarket during pandemic times, so you don't have to go to a clinic, or rather you're put off going to a clinic and therefore don't access these services? And how can we fundamentally start with a position of, well, let's stop domestic violence in homes or reduce the risk of it? So I hope what I've shown you today is just that, outbreaks are gendered, the effects are gendered, And there's a lot of relatively straightforward steps that can be taken to mitigate against some of these effects if governments want to. The problem is that without recognizing, without having this in policy, without being asked to look for these effects, governments have, and the kind of global health security agenda more broadly, have neglected to think about this to the detriment of women in the coronavirus outbreak. And I shall stop there.
Thank you so much, Claire. That was wonderful. I love looking at the intersection of women and gender and all of that. And so this was super, super interesting. And I loved hearing about it and all of the dimensions of it. So we have a couple of questions, it looks like. Ravdeep Kaur asked, when it comes to anxiety comparison between men and women, can we consider the scale used incorporates the subjectivity of men's and women's threshold of anxiety, because QOL/social environment can vary between men and women, which can influence mental health. Thank you.
Yeah, absolutely, right, absolutely, that there are nuances to this, right, and it's not just black and white. But even when you control for that, you're still seeing a difference between men's anxiety and women's anxiety, which I think is important. And it's also fair to say that that's also true around time use surveys and trying to see how men and women record what they're doing with their days and if they're doing paid work and unpaid work. There's actually quite an interesting piece of research that was done basically showing that men overestimate how much unpaid work they're doing, and women tend to underestimate how much unpaid care work they're doing. So absolutely these things are with a pinch of salt, but I think the trends are strong enough that even after controlling to those factors, you're seeing quite a significant difference between those groups.
Interesting. Aaron Sorrell asked, is there any research being done to look at gender differences in rates at which people are seeking help or professional help with mental health/anxiety challenges related to the pandemic? For example, if there are differences with concerns over the cost of mental health treatment, managing the balance of therapy or counseling with childcare, etc.
That's a really interesting question. I don't think I know the answer, which is probably very unsatisfactory. I would imagine there's also a question around who's able to seek those services. So it's probably not just male, female, but also depending on socioeconomic group as well. And I also imagine that the busier you are or the more unpaid labor you're doing, the less time you have to seek those services, which is probably also quite important. We haven't been looking at mental health specifically. We've been looking at access to healthcare in the UK, which is obviously free. So that question of cost doesn't come into it. But how your routine health provision has changed during the outbreak. And women have actively been not trying to get routine scripts or routine health services during the pandemic, even when they're available, because they simply were like, well, how am I going to fit in an hour's trip to a physician when I'm also looking after my kids and getting up at 5 in the morning to work before they wake up and staying up till midnight to finish it. So I imagine that's the same for mental health, but I don't have the data to back that up.
Interesting. Lizaida asked, what was the outcome in Panama for the gender restrictions during lockdown? Was it positive or negative?
Sorry, what do you mean? I'm not sure I understand that question.
For the gender restrictions, so I guess restricting the days men and women, did that have a positive or negative effect on?
I guess the question is effect on what? Did it stop circulation? Well, we saw a massive reduction of coronavirus as a consequence of the major quarantine. It's quite hard with the Google data to assimilate and compare to other countries. So we can't say that because of that policy, which was sex segregated, it made a difference or it made a bigger difference to the outbreak in comparison to a country which just did a full lockdown and people could choose which days they went out. But it had significant societal costs. There's been a lot of concern around increased domestic violence, women not being able to report because they can only go out on their days. We've seen a big pushback by the trans community, for example. This was a sex segregated policy based on your ID card and your sex assigned to you at birth. And so a lot of trans groups have rightly disagreed with this and have said that it's discriminatory. And then there's this question of what's it telling us more broadly around women's unpaid labor? They're doing all this work, they're not going out in public. How does that then limit sort of participation in public life going forward, for example, if schools aren't open.
Thank you. Baresh Wu asked, how can we avoid coercion or perceived coercion in early tier vaccination of essential workers? Thinking of women in the care sector, but with the overlap with at-risk populations in the US and the essential workforce.
I'm not sure I know the answer to that question. So, I mean, when you mean avoid coercion, do you mean being told to take vaccination?
I suppose when you consider the fact that there's a gender dynamic to the essential healthcare workforce, but then there's also, particularly in the US, I guess, a racial one. So how do we, or is there a way to ensure that, you know, like white women don't get access to vaccines more or anything like that?
Absolutely. I mean, you know, my belief is we should be vaccinating frontline healthcare workers first before anyone else. And that is going to be women more than men, just by the nature of it. But I don't think we should be, you know, desperately trying to ensure that there are an equal number of men and women vaccinated to begin with, because that will lead to perverse outcomes for frontline healthcare workers who aren't getting it because they are women, for example. I think that the question around vaccines and gender is really important. You know, at the moment, the clinical trials aren't recruiting based on sex characteristics. They just recruit, or they're not reporting it, right? They're not reporting whether they're recruiting equal numbers of men and women. And so that might really lead to concerns around safety, right? How do we know it's equally safe for men and for women? And look, I'm not a clinical trial person, so maybe they have thought about it, they just haven't told us. But I think there's something really interesting around that. And then around pregnant women. So from the Zika outbreak, there was a move to ensure that women could be included in any treatment clinical trials, which was against what normally happens, which is excluding pregnant women for the obvious safety reasons, but actually recognizing that if pregnant women are most at risk of Zika, we need to include them in the clinical trials. And actually, you know, the data that came out of CDC this week showing how pregnancy is an indicator, a potential risk factor for coronavirus and worse health outcomes, then I think we need to be having those conversations again around ensuring that pregnant women are part of that first line clinical trials. Is it safe conversation?
Very good. Matt Boyce asked, how do you think the list of considerations and policies, example, recognition of gender effects, sex disaggregated data, IPV, support, finance, etc., would vary with the type of outbreak, like vector-borne versus respiratory, or the severity of the outbreak, epidemic versus pandemic? That's
a really good question, and hi, Matt. I think a lot of it doesn't vary at all. So, for example, my work previously on Zika, a lot of this is the same, right? It was the same formal sectors of the economy that were shut down. You know, tourism, restaurants, they're the ones that lost trade because people were scared of going to Brazil, and those mainly employed women. We saw women having to perform this additional work in the households to basically perform the vector control to keep themselves safe. So on top of that, and then you're seeing the additional burden of the virus by you know, these women having to look after children with long-term care needs, right? We see a lot of similarities between coronavirus and Ebola. It's almost, you know, scary how similar it is. And what's more scary is the certainly in my government, the unwillingness to listen and the unwillingness for us to say, look, during quarantine in Liberia, this is what happened to women, and them saying London's not Liberia, it would never happen here. And it's like, well, no, maybe not exactly the same, but the same tenets, right? It's still women losing jobs. It's still women doing the childcare. It's still women being at risk of domestic violence because of lockdown. What's important is these effects on women don't happen because of the virus per se. They happen because of the government intervention and the response, the public health response to the pandemic, right? And that's why, and that's really crucial, because that's the thing you can change, right? You can change how governments respond to this when you can't necessarily change the virus itself. And so that's why it's kind of, we need to get this into policy so that it's thought about.
And that actually relates to the next couple of questions. So Ali asked, do you have any specific policy recommendations for how to control the spike in gender-based violence during the lockdown? And have you seen any countries that have implemented interesting or effective policies that now see lower rates?
Yeah, so a lot of countries have done, a lot of European countries at least, have done a lot around gender-based violence. And the policy responses range. You see countries that are increasing like public awareness campaigns to try and make sure people look out for it. In Czech Republic, for example, they've trained all their postmen to look out for signs of domestic violence, because they're the ones who are still going to people's houses, which I think is quite a novel idea. In other places, they've tried to be more kind of gender transformative. So whereas a lot of activity has been around getting women who are at risk or have been abused during the pandemic, they were then opening hostels. So France, for example, bought 10,000 or 20,000 hotel rooms for victims to go and stay in during the pandemic. But then you see some countries like Scandinavian governments who've gone one step further and said, why are we taking women out of their homes? Why are we taking women and kids out of their homes, putting them in public spaces like hotels with lots of other people who might then be more likely to get the infection? And so they've been removing men from those situations and putting men in those hotel rooms. And then others who've been working really closely on making sure that known offenders continue their counselling and their support during lockdown via Zoom calls with counsellors to try and, let's face it, women are victims of domestic violence because men are perpetrators of domestic violence. So rather than kind of taking women out and making their life more difficult, the decision was, let's focus on the men, which I think is a much better idea in the long term.
Yeah, I completely agree. It's always fascinating that the solution is, oh, let's move the woman and child out of their home and destabilize them rather than the abuser. So yeah, totally agree. Isabella asked, incorporating women and female issues has been a buzzword in the international system for what seems like a long time now. Is there any research on suggestions of how to move past just this lip service phase?
So I agree with you, right? There is a lot of this, there's a lot of people talking and a lot of people, not many people doing, which I think is a real problem. I think there is hope. So when I was researching my book on Zika and the gendered effects of Zika, and I was saying outbreaks are gender issues and their effects are gendered, and no one really paid attention and no one really cared. COVID has changed that, right? I mean, yesterday there was a Women in Global Health Security Summit, right? With Tedros is hosting meetings around gender and COVID. We are seeing a change. Now, the cynic in me is like, well, this is only changed because it's affecting white Western women in the UK and the US and Europe, and suddenly women are like, I can't cope, and that's why it's happening. And the cynic in me is like, that's disgusting, and it's disgusting that's what it takes to make a policy change. But the other part of me is like, if that's what it takes and it's going to make a change, then let's just go with it, right? And I think the real crunch will be what happens next, because there's one thing to shout and scream and say, listen, and I think we've now got not every government, but some governments listening and some global health institutions listening. The question is, are they going to do anything about it? And are they going to do anything about it at the cost? All policy is it's a push and pull. What's going in, what's going out? Are they going to prioritize it over anything else? And I think that remains to be seen.
Yeah, it's interesting because when you were talking about having the right people in the room, because like you mentioned, nearly, I don't want to say the exact same, they're different outbreaks, but similar things happened with Ebola and Zika, and we just had those outbreaks. And I mean, just like we just learned, there were such gendered effects. And so with coronavirus, I mean, there was a lot of issues with just policymaking in general, at least in the US. But why wasn't this pulled? There was a bunch of research, you had mentioned your book, and I'm sure a bunch of other research about it. And so is it really just like these global leaders that are men mostly just not thinking about it? You said there aren't the right people in the room, but this is 50% of their population. Why aren't people asking these questions?
Yeah, I mean, I think it's just that, right? I think it's they just don't they just don't think. Like, I think that policymakers, well, I can only talk about my government because it's the one I've been working most closely with. They don't even think about it, right? It's not that they're actively not including women, they just don't think about it. And, you know, there's been a lot of conversation here in the UK around, oh, it's because there's no senior women in our cabinet. And it's like, no, there are. They just don't think about the gender effects because, like, that's there. And, like, being a woman doesn't mean you think about these things. And I think even more importantly is when you compare outbreaks to other areas of crisis management. So when you compare it to humanitarian disasters, when you compare it to climate change, both of those at the global level, at least, there's a requirement for a gender impact assessment on all policy that comes out to mitigate against these things. And so if that's happening in other spheres of governance, why isn't it happening here, right? It's not a big job, right? It's just recognizing that everything has an effect. And, you know, why do we not want to do that, really?
Yeah, very interesting. If other people have just last questions, ask them now. I'll also ask, just out of curiosity, you know, a lot of this, so we've talked a lot about the policy, which I'm super interested in, but also there's this social component and the sociological component of this is a cultural thing with women, you know, like the second shift and women taking on more of the housework and, you know, these, you know, like you said, domestic violence, it is mostly men perpetrating it against women. So then these other spheres of life that the government can't, at least so directly, influence, what do we do with that too?
But I think it's about, you know, setting behavior you want to be replicated. Like, I think a lot of this is, if you talk about the sort of the gender imposed constraints on society, right? Like, why is it that society doesn't think about women? Why is it that policymakers don't think about women? And actually it's kind of top down and bottom up, right? And so you have governments that don't think about it. I speak broadly, you know, most governments don't necessarily think about the impact of their policy on women. And they don't think about it because there's either not women in the room, there's not gender advisors in the room, it doesn't even cross their mind. When it does, it seems like a kind of not as important, you know, it's all about the economy and it's all about, you know, that's the focus. And so you kind of set an agenda at the kind of top down level, which is like, we don't really care about women, or we don't value the contributions that women make. And that then leads to this kind of norm diffusion where you have societies also thinking the same, right? Families thinking the same. And that's why you get these sort of gender divisions of labor in households that I was showing you. And, you know, you see that really acutely. We've been interviewing families all over lockdown, and just the way that women talk about, like, their setup during lockdown, and it's like, oh, well, obviously, you know, I gave up my job because it was like untenable and it made my husband so stressed having to manage this. And it's like, well, okay, but like, what about him making you stressed? Like, you know, and it's these gendered assumptions which kind of, they sort of bottom up and top down. You know, it made me really, as a researcher, it's really difficult because you listen to these stories and you want to just be like, but you have to kind of hold your own and be like, all right, interesting, yeah, great, yep. And it's just kind of, it's infused. And even if you think you're in a progressive society, there's a lot of people who don't necessarily think about more issues around gender equality.
Well, we are almost at time, and so I just want to thank you so much for speaking with us for our first virtual event. I loved it. It was super, super interesting, and I hope everyone goes from this thinking about, you know, how can we as individuals and, you know, supporting policymakers support more gender focused and gender understanding policies and just thought. So thank you very much for speaking with us today and sharing your research. And also, you know, as a woman and a mother, thank you. We can't talk about the gender differences and the effects of like quarantine and being a parent without also acknowledging you doing all of this wonderful research also as a parent. So thank you for all of your work. Thank you for speaking with us. I had a lovely time, and thank you to everyone who joined us this morning, or morning for me, and asked questions, and this was really, really wonderful. So thank you so much.
No, thank you so much for having me, and anyone feel free to reach out if you want to chat about anything more. I always love chatting about this stuff.
Wonderful. So we'll hang out for a second, but folks are free to leave. I'll end it in a second, but thank you so much for joining us today. And we will be having another seminar in a month. We'll announce the speaker then for Biosecurity Month in October. And thank you so much.